So now we are going to start stomach. In stomach, we will first start with anatomy of the stomach. As you can see here, this is esophagus and this is stomach. Okay. So in stomach, this is cardia. This is angle of his. This is fundus. This is body. Here we have antrum. And this angle is incisura angularis. Okay. And here we are having pylorus. This is regarding the anatomy. Now, in all of these structures, they are having some different disorders which are more common in particular region of the stomach. Okay. So now these are very commonly asked questions. Like cardia is the most common site for Mallory-Weiss syndrome. Okay. Then gastric fundus is the most common site for stress ulcers and carcinoma stomach in patients with pernicious anemia. Okay, then gastric body is the most common site for gastric pacemaker cells. And what is the other name for these gastric pacemaker cells? They are also known as interstitial cells of Gall. Okay. Now, antrum is the most common site for carcinoma stomach. And incisura angularis is the most common site for gastric ulcers. Okay. Most common site for gastric ulcers. So these questions are very important regarding the anatomy. Then the next topic is blood supply. Okay. So as you can see in this diagram, that stomach is having a very complicated kind of a blood supply. Okay. To make it simple, I will redraw it here. This is stomach. Now, the lesser curvature of the stomach is supplied by left gastric artery and right gastric artery. Okay, whereas the greater curvature is by right and left gastroepiploic artery and short gastric artery. Okay, so now you can see here, just see in the diagram, like this is the left gastric artery. This left gastric artery is originating from here, and this is what? This is celiac trunk. So left gastric artery is a branch of celiac trunk. It is actually a direct branch of celiac trunk. Okay. Then you can see here, this is right gastric artery, and here left gastric and right gastric are making a connection. Okay. Now this right gastric artery in majority of the cases is a branch of proper hepatic artery. Okay, you can see here in this diagram it is coming from the common hepatic artery. So right gastric artery can originate from I'll write in the next page. So right gastric artery can originate from the common hepatic artery, proper hepatic artery, but in majority of the cases, in 53% of the cases, it originates from proper hepatic artery. Okay, so this is regarding the lesser curvature of the stomach. Now you can see here on the greater curvature of the stomach, we have here right gastroepiploic artery, then left gastroepiploic artery, and in the top we are having short gastric arteries. Okay, so this right gastroepiploic artery is actually a terminal branch of the gastroduodenal artery. Okay, so as you can see here, this is not the gastroduodenal, this is actually the gastroduodenal artery. Then this gastroduodenal artery goes down and it divides into two branches, which are the superior pancreaticoduodenal and the right gastroepiploic artery. It is actually a terminal branch of the gastroduodenal artery. Okay. Then comes the left gastroepiploic artery, which is actually a branch of, here you can see this is the splenic artery. Splenic artery is going behind the stomach, and then it is supplying inferiorly as left gastroepiploic artery and superiorly as multiple short gastric arteries. It can also give a smaller branch on the posterior wall of the stomach as posterior gastric artery. This is to make you understand. Now I'll again write. Now left gastric artery is a branch of celiac trunk. Okay, and celiac trunk is the direct anterior branch of aorta. Then right gastric artery is a branch of proper hepatic artery in 53% cases, followed by common hepatic artery. It can originate from both proper hepatic and common hepatic, but in majority of the cases it originates from proper hepatic artery. Okay, then right gastroepiploic artery originates from or is a terminal branch of gastroduodenal artery. Then the left gastroepiploic and short gastric and posterior gastric artery, these all are the branches of splenic artery. Okay, you can see here stomach is actually supplied from the branches of celiac trunk. Okay, then hepatic artery, then the gastroduodenal artery and splenic artery. So there is not a single gastric artery, it is supplied by multiple branches which are actually originating from different arteries. So that is the biggest reason we can divide one artery and still the stomach will be viable. Okay, so that is the basis of forming gastric conduit in patients with in patients who are undergoing esophagectomy for cancer esophagus. And gastric conduit is actually supplied or is based on which artery? This is a very common question, and the gastric conduit in cases of esophagectomy is based on right gastric and right gastroepiploic artery. Okay, right gastric and right gastroepiploic artery. Okay, in case if only one option is given, then we should go for a right gastroepiploic artery as it is a bigger artery and it is the main artery among the two who is supplying the gastric conduit. Okay, now we are coming to the nerves of the stomach. Nerves are very important. Now suppose this is esophagus, this is stomach. Now I will make nerves here for you. Okay, we have two vagus nerves supplying the stomach. The left one is anterior, left vagus is anterior and right vagus is posterior. Okay, so this vagus nerve is coming here anteriorly. It is giving some branches here and then it is going into the stomach and giving branches like this. Okay, so suppose this is left vagus. This left vagus is giving branches. First branch is to the liver or the hepatic branch. Then the second branch is towards the celiac axis, celiac branch. So this left vagus is coming directly as a trunk, then it gives branches to the branches as hepatic branch, then celiac branch, then it divides and gives multiple branches into the stomach as a crow foot. Crow foot is the terminal branches of the vagus. Now, if we see the posterior vagus, the posterior vagus is coming from behind and is also giving branches like the crow foot. But before supplying the stomach, there is a branch or the first branch which is even above the trunk, even above the gastroesophageal junction. That is the criminal nerve of Grassi. Okay, so the first branch of the posterior vagus is the criminal nerve of Grassi. Now I'll explain them to you. Okay. Now this is stomach. Here we are having left vagus, which is giving branches, that is hepatic as well as celiac. And then it is giving multiple branches to the stomach. Okay. If we are dividing the vagus at this level, then we call it as a truncal vagotomy. And this truncal vagotomy is actually division of the nerve trunk. Okay. Division of main trunk will be known as truncal vagotomy. If we are dividing the vagus after the branches of hepatic as well as celiac, then this will be known as a selective vagotomy. This selective vagotomy is actually after the hepatic and celiac branches. And if we are dividing these branches, which are actually the seromuscular branches, division of seromuscular branches, the division of seromuscular branches will be known as highly selective vagotomy. Okay, so the division of seromuscular branches of the nerves will be known as highly selective vagotomy. Okay, and during truncal vagotomy, we are dividing both anterior trunk as well as the posterior trunk. Here comes the significance of the criminal nerve of Grassi, because it is dividing even before the level of the truncal vagotomy. So that is why this nerve might get missed and will lead to recurrence of the peptic ulcer disease. Okay, so the criminal nerve of Grassi is actually the branch from the posterior vagus, and it lead to increased recurrence rate, okay, of truncal vagotomy. Okay, now comes the point that among these three vagotomies, which is having the maximum reduction in the acid output. So as it is obvious that truncal vagotomy will be the best in terms of the reduction of acid output, but it is associated with more complications or morbidity. So truncal vagotomy is having lowest recurrence rate but maximum morbidity. On the other hand, this highly selective vagotomy, this HSV is having maximum recurrence rate but lowest morbidity.